Right, and finally, last but not least, by any means, we have Dr. Carol Pedden, who's going to talk to us about the National Emergency Laparotomy Audit and the impact of integrating audit with QI methodology research. And I think, very much building on the story that we've been hearing today. So Carol is Professor of Anaesthesia at the Royal College of Anaesthetists. She's also Associate Medical Director for Clinical Quality, NHS England South, consultant in Anaesthesia and Intensive Care, Royal United Hospitals Bath, previous IHI Fellow, where around about the same time as Kevin, I believe, has a Master's in Clinical Effectiveness from Harvard, and most importantly, and relevant to her talk today, founder and quality lead of the Emergency Laparotomy Network.
I like the way Kevin leaves as I come up to just get the slides up. Right, thank you very much, everybody, for inviting me and giving me this opportunity to talk about the National Emergency Laparotomy Audit. It's actually billed on the agenda as the NELA story, and so I am going to talk a little bit about the NELA story, and I'd like to thank my NELA colleagues that are in the room, and also the colleagues I've worked with on some of the studies I'm going to talk about today. How many of you are surgeons or anaesthetists? Nobody. Okay, so I maybe just better tell you a little bit about what a laparotomy is. This is, if you're a patient, probably a very, very scary thing to have happen to you. You present with acute abdominal pain, or you might present to physicians with grumbling abdominal pain, but you end up having an emergency procedure, often late at night, in an operating theatre. For those of us who are trained in anaesthesia or surgery, this is what we grow up doing at night. It is, and Dominique talked about relevance to people, and I think one of the successes of this audit is going to be it's highly relevant to clinicians on the front line. I started looking at the data. I'm going to tell you a little bit about the story of NELA. I started looking at the data many, many years ago when I was a senior registrar, so you can tell how long ago that was. It was 25 years ago. And I was stunned. People at that time were beginning to talk about the outcomes for fracture neck femur not being very good in the elderly. And I was stunned to find they were 10 times worse for this procedure, which is very common. In a hospital like Bath, which serves about 500,000 people, it's a medium-sized district general hospital, we will see one of these patients a day, and emergency general surgery is one of the biggest hospital specialist areas, and the Royal College of Surgeons and Association of Surgeons describe it as the Cinderella specialty. So I was stunned to find that these patients, particularly the elderly, had an up to 40% mortality within 30 days, and nobody was talking about it. We published over the years at Bath our outcomes, and I always say when I'm talking about this, a credit to our surgeons, because to publish data that says you have up to a 40% mortality is a little bit scary. This paper was picked up by an editorial in the European Journal, which said, well, this is an interesting problem, but it's one hospital's data. This paper showed a 17.5% mortality on average at 30 days and a 40% mortality in the over 80s. I then, on the basis of my interest in this, applied to the Health Foundation for a fellowship to go to the States and look at how we might bring about improvement for this high-risk group of patients. So I came back, I met these colleagues, particularly Dave Murray. It was just one of those conversations that you have at a meeting, and we said, let's get together and collect some data on this. So we got 35 interested hospitals to pool data, and we produced this first sort of national prospective audit survey, which showed, again, big variation, and again, up to 40% mortality in some hospitals. That then created the energy for particularly Dave Murray and Mike Grocott to go to HQIP and apply for funding for a national audit. So thank you very much for enabling us to do this, and it is a really important problem. Everybody knows, everybody who trains in anaesthesia and intensive care and surgery will know that you don't send an esophagectomy patient back to a ward after massive surgery. Yet, these days they have an average mortality of 3%. many of our patients having emergency laparotomy go back to a ward. Prior to this study and the energy that this major audit has created, these patients were just sent back to wards. And still quite a lot of them are. And yet we were tolerating a death rate that we would never have tolerated with elective surgery for this group of patients. Cardiac surgery, the UK outcomes are amazing, much of that improvement driven by audit and the publication of outcome data. If you have a cardiac procedure in the UK now, your mortality is about 1% to 2%. You will go to a high dependency bed. Nobody would start an operation without that. And yet, these emergency laparotomy patients haven't always had that level of care. It's not just a problem of the UK. Interestingly, big data from the US, the US National Surgical Quality Improvement Program, which is a huge database, has the same mortality. And in the Danish cohort study below there, they have an even higher mortality. So this is an international problem. So I think if we can get solutions in the UK, they are internationally applicable. This is a HES database study from Omar Faizi's group at Imperial. And interestingly, it came out with the same kind of data we saw from our prospective study. What they did using HES data in this study, though, they were able to note that there were high and low mortality hospitals, and they were associated with the use of critical or high dependency beds. So if you had more critical care beds, your patients did better. And also the use of scanning perioperatively. So if you had a more proactive approach to CT scanning these patients, the patients had a better outcome. So that's the kind of links that we want to see with the NELA audit. What is going to make a difference to these patients? So we were funded for 3 years, subcontracted for analysis to the Royal College of Surgeons, based just across the road. Literally, you can see it. In fact, I did wonder if I could run between this meeting and another one at the Royal College of Anaesthetists just now. So based at the National Institute of Academic Anaesthesia across the road, and to enable the improvement of the quality of care for patients undergoing emergency laparotomy. So we have completed the organisational audit. So that's where we looked at, the relative numbers of high dependency critical care beds per hospital, whether, and we have an NCAPOP director in the room. NCAPOP in 1987 called for emergency operating theatres being available all night to patients. In this audit, we find that that still is not the case in every hospital in the UK. Whether surgical staff are free from elective commitments so they can actually go and operate on one of these patients, etc., etc. It was published in the summer, and red means you are not fulfilling criteria. These are not necessarily evidence-based criteria because there isn't much evidence, there's not been much research on this group of patients, but these are consensus standards. Some of them from some of the NCAPOP reports, some of them from reports we've subsequently had or around the same time from the Royal College of Surgeons, anaesthetists, etc. But you can see there's a lot of red. And as a frontline clinician, I know that my junior doctors want to go off and do little small audits of their own. Why would they when we've got all that to do, all that to look at, all that to question, all that to sort out? So there's a lot there, and things you can't read it, but there'll be things like, does your hospital have sepsis pathway management standards, for example? So things that you would expect would be available these days. So an IHI saying, while all changes do not lead to improvement, all improvement requires change. So we now have some standards. NCAPOP did Knowing the Risk about high-risk surgical patients a few years ago. Of course, it's not just emergency laparotomy, but emergency laparotomy is a large group of the high-risk surgical patient. And Ian Anderson authored this paper, which I was an author on as well, of the high-risk general surgical patient, where we set some standards. Previously, there were none. And as you know, with audit, when you have standards, you can then audit against them. So these are some of the things that are giving us the standards that we're using in the NELA audit. So some of the recommendations about changing the delivery of care in emergency laparotomy: preoperative risk estimation, so understanding what your patient's risk is before you start the surgery, so that you can have an informed discussion with the patient, the family, involve intensive care where necessary, etc. have clear escalation strategies. We have limited or relatively low numbers of beds, of critical care beds in the UK. So we need to understand which of these patients need to go to critical care if we can't send them all there. Clear diagnostic and monitoring plans and what's the best time to get to surgery. We're collecting data on individual patient risk, the processes of care, and perioperative patient outcomes. And just some demographics. You can see on the age group, this is mainly an elderly population we're dealing with. The mortality is high in young patients, though, as well. But, you know, a lot of our patients are 70, 80 years old. ASA3, the American Society of Anesthesiology ranking of risk, so this is relatively high risk, and we know from the network paper we did that if your ASA score is 3 or more, then your risk of death is at least 10%. There are some patients in this study classed as elective. That's probably they're booked. You know, there is sort of two groups of patients, which makes data interpretation sometimes difficult. There'll be the people that come in through the door that are very sick and need to go to theatre straight away. And then there will be people who have maybe a cancer that's obstructing the bowel that the surgeons might try to manage conservatively for a couple of days and then take to theatre. So some of those patients might fall into an electively booked procedure. It's about slightly more female than male patients, perhaps representing the age spread. So this is up-to-date data from the NELA database. The overall inpatient mortality is 13.6%, which is slightly down. Now, I'm not going to speculate on that, but well, maybe I will a little bit. I just think the energy around having this national audit is making people look at their outcomes. And 30-day inpatient death, 12.4%, which is definitely down. We're looking at bivariate analysis, so age, does it make a difference? Your age, your ASA, preoperative risk stratification. Preoperative PPOSM is a tool to analyse risk and your urgency according to the National Confidential Inquiry urgency stratification. And again, you can see that the mortality, as you get older, your mortality risk goes up. And we're still seeing in the over 80s this really quite high death rate. This is looking at, in the current data we've collected, whether patients are having a risk stratification preoperatively. And you can see that perhaps 10% of hospitals are still not doing that. So there's straight off one area we could improve. And quite a significant number of patients have a greater than 10% risk of death recorded prior to surgery. Key process measures. We're looking at delays to surgical intervention. We want antibiotics given on time because often these patients have sepsis. We want senior, given the relative mortality, we want senior personnel in the operating theatre. And ideally, we want the highest risk patients to be going to a post-operative critical care bed. Just looking at the last, where are we? You can see that we've got quite a good number now of patients, increasing numbers of patients going to a critical care bed. There is still room for improvement, though. So how are we going to drive quality improvement? Well, we're producing yearly reports, so we've already stimulated discussion with that organisational report. Process and outcome measures that can be incorporated into trust quality accounts. Local download of results are available. Now, this is something, and I'll talk about how I know about this later, and Dominique referred to it, I don't think, it's not particularly evident that local teams know that they can download their data for their local use. There is a sort of feeling that they're putting data into a national database somewhere. And I think that's one of the messages in this audit we really need to get across, that teams can download and use their own data. And we're doing lots of talking at workshops, regional, national meetings. I spoke last week at a Royal College of Surgeons meeting, and there's a lot of interest in this group of patients now. So I'm just going to talk a little bit about quality improvement and some of the things that I've been involved with and some of the things we've seen. I really like this slide because I think the way we've been working with these patients, this is an American slide, But I think the same applies in the UK. We've had a fairly traditional approach that these patients would come in. The emphasis has been on the delivery of elective care. The resources haven't necessarily been there always for emergency surgery patients. They've been subjected to diagnostic delays getting into an operating theatre. We've taken a kind of, when they get into trouble, then we'll pick up the pieces approach. And I think we need to be much more proactive about how these patients are really sick and getting them to theatre fast, operating fast, and being very proactive in supportive management with them. So I'm just going to show you a study which we started using the network data, but essentially the network, much of the network data, the measures are the same as NELA. And this shows what can be done, and then I'll show you how we're going on to use that with some of the NELA data. This was funded by the Health Foundation, and for those improvement science purists in the room, of which I am often one, we slightly cheated on the bundle concept here, which you might see in a minute. It was a group of 4 hospitals did this, and we called it the Emergency Laparotomy Pathway Quality Improvement Care Bundle because we like funky acronyms, so it's HELP quick. And what we did was concentrate on a few key measures, and we divided it into 5 domains, which is why we cheated it and called it a bundle, but you can see there's actually a few things in each domain. But things like, did the patient have an early warning score recorded? Were they seen, as is documented in the high-risk surgical patient document, by somebody with a higher surgical qualification within 30 minutes? If they had signs of sepsis, were they given antibiotics? We coined this thing code emergency laparotomy for the radiologists who really like that. And that means this patient needs a CT scan now and should get it within 2 hours. From when the surgeon makes the decision to operate, because of course there is a group of patients that the surgeon may try not to take to theatre, but from the time they decide, yes, we need to go to theatre with this patient, it should be 6 hours from that decision to getting into an operating theatre. We're using goal-directed fluid therapy, which is a means of promoting cardiac output in theatre and afterwards. And in this study, we aimed to send everybody to a critical care bed. Now, this is the difference between perhaps quality improvement and a randomised control trial. We knew that we couldn't always meet all these measures, but we were pushing to improve our process delivery. We knew it would never be possible, probably, given the numbers of beds around, to get every patient there. But the aim was to try, and I think that changes our thought process around these patients. Instead of sending them back to the ward, they then become an ICU patient that we're trying to manage in the theatre recovery area. So just some of the process measures in this study. Decision to theatre in less than 6 hours. Every hospital improved. You can see that nobody by any means got to perfect, but we all moved in the right direction. Consultant anaesthetists in theatre, and I have to say, the surgeons are always better than the anaesthetists at this, but in all cases, anaesthetic presence increased. We've just had the paper accepted for publication in the British Journal of Surgery, and there was a highly statistically significant improvement in lives saved across the 4 hospitals. There was about, I think it's roughly 400 patients in the baseline and 400 patients across the 4 hospitals afterwards. So quality improvement can make a difference. If you look at these improvement polygons, so if you are performing very, very well, every colour would be at the outside of the polygon. And for the 4 different hospitals, you can see we all improved in different areas, and we all have different areas that we can work on. And as I say, none of us are performing all round at a high level, but we still made a big difference to patient outcomes. So that leads into the EPOC trial. This is a National Institute for Health Research funded study. Large amount of money, £1.5 million. Principal investigator is Rupert Pearce, who's a professor of intensive care at Queen Mary's. I'm the quality improvement lead, and we are using the NELA data in this national study to look at whether quality improvement makes a difference. And this is very useful to me as the QI lead on the NELA board, because I'm actually going out there into, this is 90 hospitals around the country, so I spend a lot of time on a train. We're going out into the hospitals, I think Dominique referred to time for reflection and improvement. And one of the things about the EPOC study is we're getting a group of senior, it's very high consultant attendance. We've got consultant anaesthetists, consultant surgeons, and consultant intensive care physicians in a room for a day to talk about this problem and to start introducing them to quality improvement methodology. And one of the things that we get them to do before they turn up for our day is to download their NELA data and look at it. And if they don't know how to do that, we help them. Many of them will not have looked at their NELA data prior to this. So that's the first bit of learning, that people aren't necessarily accessing their data, even though they know the EPOC trial is coming to town and we're going to ask them. They might not have done it. But when they do it, they find it very useful. I think also Dominique referred to the fact that people need statistical process control charts. Well, I think the concept of a run chart is actually relatively, all doctors will understand a timeline, but the terminology they won't get. So we have to help people with this. And one of the things we're planning to do with NELA is to provide run charts of mortality, length of stay, and outcome data. What we are finding is, as we would expect, is there's a huge amount of enthusiasm for this study, and we're coaching teams in quality improvement. We're very much leaving what we're actually doing is just helping people to understand how they might make quality improvement happen and use their data. We are not telling them what to do. So each team can work out where they want to improve, get the data from the NELA data, and then go and use it, and then look at how they're improving. So I think that's a very interesting combination of being able to feed back how we're doing with this into our NELA learning. So I think that's the NELA story, some of the ways we're using quality improvement. I think the ELP-QUIC study shows that we can make improvements in this high mortality rate, that I would suggest there's a lot about standardising pathways of care, which doesn't cost anything. We're in a very financially constrained times. Local data from my hospital in Bath, we didn't show it across the 4 ELP-QUIC hospitals, but in Bath we showed a slight reduction in length of stay. So that's going to actually lead to some cost improvement. I think we need a sense of urgency, and I think there is a sense of urgency and real engagement around this project. Clinicians, nurses really get this. And the National Emergency Laparotomy Audit is giving us the data to drive improvement. And I firmly believe improvement does not happen without data. And I think there's a focus on reliability. Don Berwick said reliability means keeping promises. And that means if we say we're going to treat a patient who's septic before bowel surgery with antibiotics, we get them into the patient in an appropriate timescale. We get them to theatre in what we believe is the optimal time. So I like these 2 quotes. Without a standard, there's no logical basis for making a decision or taking action. And from Deming, in God we trust, all others bring data. So I think the future is here. NELA is powering quality improvement for emergency laparotomy, and I think data is power. Thank you.
Carol, thank you so much. Absolutely fascinating. Lots in there for us to consider. I think interesting the link back to the clinical outcome review program, the confidential inquiry work of NCAPOP in informing your study, but also imaginative sort of partnerships with other organisations to support your quality improvement. So, questions for Carol, comments?
Everybody wants lunch, I think.
Just warming them up. There we go.
Lovely presentation. Thank you very much indeed. I'm interested that you got NIHR to fund this essentially improvement project, which is fantastic. The other direction in which the use of national measurement data may take us in the direction of randomized registry trials. And I don't know how many people here are familiar with the study published from Sweden recently, the TASTE study. So this is where they were looking at thrombolysis aspiration for ST elevation myocardial infarction. So they added that in to routine care. But they used their national registry of myocardial infarction as the basis on which to assess the effectiveness of this intervention. So rather than setting up a really expensive randomized clinical trial, they used the resource of having a reliable registry with measurements of outcomes of myocardial infarction to assess the impact of this change. And the interesting thing was, you would think that it would be bound to be beneficial to have your thrombosis aspirated, but they've shown that at both 6 months and 12 months, it makes absolutely no difference at all. So that's, I think, getting this bridge between improvement and establishing a firmer evidence base is a direction we should all be aspiring to go, and I think that's fantastic work.
Yeah, I think a lot of credit due to Rupert Pearce, the principal investigator on this, but we do have a great team, and I'm sure one of the strengths of the application to the NIHR grant was the fact that the data was being collected, it was set up, and we had a very good team already doing that.
Thank you. My name's Chris Hardy. I'm a member of the Service Users Network on the Health and HQIP. But it's actually wearing my hat from one of the things that's brought me to HQIP, which is I sit on mental health tribunals, and I've been looking at, listening, running through my head as I've listened to all the presentations this morning, has been this. And that is orphan concerns, if I can describe it that way. I want to take revolving door mental health patients. My work means that I sit across a number of trusts, lots of different hospitals, probably about 80 times a year. And among patterns with patients that are coming up now, not all, but coming up, and my question is, and I want you to be thinking about this, how do you get this into the sort of research agenda, getting the sort of quality of investigation and audit that you're talking about this morning? We will be talking to doctors, we now being the tribunal members, because we cross-examine and so on. We'll be talking, and we'll hear at times, yes, well, this patient has been in 6 times in a year through this procedure, and we've discharged every time because we've stabilised them on their meds. And then you say, well, they need more than that. Yes, they say, but we can't keep them in longer because otherwise we're accountable to management. We have to explain. It's part of cost cutting, or it's seen as, right, talking therapists are the way now, so get them back out into the community, having got them. It all sounds good, and in many cases it will work, but clearly you need to identify patients that you're seeing where this is in fact exacerbating problems. And very often the patients, because of being part of their illness, aren't necessarily going to be their own best advocates, because when they're in acute phases, they're not in a position to be being proactive and on their own behalf. So that's the issue that I'm raising now, is looking at how, when we're in cost cutting, when we're in something that goes across, and I see the national things like Carol's been talking about, across getting lots of places to do this research, but very often clinicians tell us, so, well, actually management are a bit averse to looking at this because clearly it could mean extra costs. So it's that aspect that I've been looking at and listening to this morning, where you get concerns that are orphan because they're not going to be high priority, they are difficult, and actually they promise possibly headaches rather than benefits as well. So it's questions around that. I'm not expecting to have all the answers, but what I've listened to, as with Kevin this morning and then through, say, running this through, it's lots of ways it could touch, but how to get it into the field and being looked at.
Well, when I'm talking to colleagues, I always say doctors have got to be cleverer at understanding business cases and the data. And if you have this kind of data, that European journal study I showed, I presented that study when I was at IHI, and I showed the length of stay, and 25% of patients were still in hospital at 30 days. And if you're still in hospital at 30 days after emergency laparotomy, as a patient, you're probably having a pretty miserable time because your bowel's probably broken down. It's probably really horrible, but that also talks to a chief executive. He wants to know why 25% of those patients are still there at 30 days, and they're very interested in how do we make that a much more structured program, better for the patient and better for the way we're using our resources. So I think understanding how you persuade people that investment up front to make the better care faster to access, which will lead to better outcomes for everybody, will also be cost effective. I mean, in the NIHR study, we've got health economics input into that. So I really hope that's going to show that if we can improve things, it is better for everybody.
I wanted to go back to a question that was posed by one of the previous speakers about what HQIP should be doing more around quality improvement. And actually I thought one of the purposes of the seminars really is to bring NCAPOP and other projects together, audits and inquiries, as a community to help guide and shape the programme. So I wondered if this was an appropriate moment to ask everyone here, what do you think we could do more? And is there generic work that we need to be supporting about quality improvement across the programme, or is it more about fighting for resourcing at areas specific that, that like you've managed to get with NIHR, that actually bolt onto specific projects, or is it both, or other ideas?
No one's mentioned maybe feeding into medical education or nursing education, because that's how the culture is going to change in the longer term. So there's the immediate and the medium-term problems of getting people engaged who are currently working, but maybe feeding more into how you interpret data. What do you do? What is the importance of audit? Right from year one, medical training, nursing training, across the board, so that once they get into the profession, they're much more likely to understand and buy into the whole quality improvement process.
Yeah, I completely agree. I think what I'm talking about more and more is I'm actually seeing almost two sorts of audit. I think there is a spectrum, but I think a junior doctor can achieve a lot by understanding about sampling. Just sampling 10 sets of notes and seeing if there's a problem. And if there is a problem for something that you don't like antibiotics on time, then you don't need to look at 3 months of data. So there's the kind of the small sample, and then the use of the big data, national audit, rather than what a lot is happening a lot of times is, just small audits that then don't contribute to very much. And I also think you're absolutely right. How to understand data and how to do basic quality improvement and understanding reliability, that we don't necessarily deliver care very reliably, and how you make that better.
I was just wondering whether HQIP has a role in picking up the issue that was raised by the colleague across the room. Carol identified that there is a health economic component to the work that she's doing. And I think a number of us have found that it's following health economic studies that we sometimes get our foot in the door. And if it's not too inappropriate, I would say that in diabetes, we got our foot in the door with diabetic foot disease through a health economic study. That's how we got it onto the agenda, by demonstrating how much hidden cost there was in diabetic foot disease and demonstrating what the mortality was. It's much higher than for colorectal cancer, for example, but it was flying under the radar. So I don't know whether, when an important issue like this arises, whether HQIP actually has a role in sort of getting the thing, helping to get the thing on the agenda by commissioning that sort of study, which is kind of out with its comfort zone, I suspect.
And I guess it's a really interesting question, and we're trying to work closely with the funding body, which essentially is NHS England for the most part, and have those difficult conversations. Because, as you said, Carol, the reality is there's a constrained budget. We've got a large programme. So what we've got to work with them with is getting beyond the conversations about X for X program, actually seeing it as a whole. And is there a possibility that we can have some, because what we don't have at the moment is any contingency funding other than we get money in that goes straight back out to the programs again. And what I think we're increasingly feeling would be valuable will be to have some funding to look at some of these more creative ways, particularly, be that health economics, looking at orphan areas, addressing issues around mental health. I mean, I think there's a need to be able to do some of that exploratory work and to have some funding to be able to do that.
It was just a thought, actually, in response to Yvonne's question. The thing that struck me today, actually, is how many of us are all collecting organisational data. And certainly we've asked the same questions that are now being asked in the NELA data, in the organisational questionnaire, about how many beds and what facilities are available. And I wonder if there was a way that perhaps HQIP could commission or take charge of pooling organisational data by hospital, by trust, so that we actually didn't have to ask those questions every time. We could go in and all put all our organisational data in with the approval of the trusts into one pot and all download it as and when, save keep asking the same questions. Just a thought.
And a very good one. So we're taking notes. We're on the roll now. And please keep them flowing in terms of good ideas, and both now and afterwards. Like, we're really keen, because I think we're all here driving, striving towards the same end, which is improved outcomes for patients within the constraints of a budget. And I just think it's about trying to be as imaginative as we can and creative as we can with the budget available to us. So very keen to hear your ideas on that. Yvonne.
Can I come back? I mean, I think that's an excellent idea. My question back would, do you think as a community we could come together, design a data set and have confidence in that data? Because obviously each project loses some autonomy over data questions, over the control, over the quality, etc. So is the will there to do that?
Well, I suspect the will there would be from the community to do it, because there would be specific data for different studies that would perhaps need to be collected in addition to the core data. But I think a core outline of how hospitals are set up, primary care is set up, number of beds, number of services, whether you have a CT scanner or not, that sort of thing would be really easy to do. I mean, we've certainly shared our organisational data in the past with other organisations to save them collecting the same thing. But it's only if that's a chance conversation or somebody approaches you. So I think a core data set that then could be added on as and when required, because, of course, maintaining it and making sure it's up to date is the key thing. But I haven't really thought about it beyond that. I can give it some thought.
Thank you.
We might have time for just one more. Desperately hungry. Right, well, we've just hit 1 o'clock. Thank you so much for listening and participating so enthusiastically. Lunch is now available. I believe it's between lunch is available in the restaurant, so just turn right out of the door. I would encourage you, if you have some time, and I know everybody's incredibly busy, but we have got this room until 3 o'clock, so if anybody would like to come back after lunch and use the opportunity and the space to share, network with others, and obviously HQIP staff will be available to chat with you, that would be great. Thank you very much indeed.